Welcome back to the deep dive. Today we're aiming high. We want to take a really complex set of specialized medical sources and, well, help you build that knowledge base of an elite professional. We're tackling a very specific, high-stakes area, really mastering how to manage gynecological conditions that pop up alongside severe obstetric challenges during pregnancy.
Yeah, and this is a field where, diagnostic nuance is everything. We're not just talking about memorizing lists of conditions.
Right.
The goal here is to understand why. Why do those normal physiological changes you see in pregnancy, like increased blood flow, tissues getting softer, all those hormone surges, why do they so often mask or even mimic underlying problems?
That's the core of it, isn't it? Spotting the signal and all that noise.
That's the mastery we're aiming for.
Exactly, because the pregnancy itself isn't just happening at the same time, it's actively confounding the picture.
Absolutely.
So we're diving deep into the protocols, the reasoning behind them. And we'll start with something that might seem simple, but it really highlights these changes straight away. Abnormal vaginal discharge and common cervical changes. Okay, let's unpack this first part.
Okay, so first things first, we need to establish the baseline. Pretty much every pregnant woman experiences an increase in cervical secretions and also vaginal transudate.
Okay.
And this is completely normal, physiological. It's driven by that massive increase in blood flow, the vascularity to the pelvis, and, the hyperestrogenic state. Very high estrogen levels.
So if a patient comes in reporting more discharge, how do we actually reassure them it's likely normal? What are the key things we look for?
Well, normal discharge during pregnancy is typically thick, kind of mucoid, and this is crucial. It has to be non-irritating. No itching, no burning.
Gotcha. Non-irritating.
And if you were to look at it under a microscope, you'd mostly see these cornified squamous cells, maybe just a few scattered pus cells, but not many.
And the management for that?
Purely conservative. Just advice on improving personal hygiene, no medication needed, nothing like that.
Okay, that sets the standard clearly. But the moment irritation or maybe an odor or a change in color comes into play, then we have to think infection, right?
Immediately.
Yeah. Let's start with Trichomonas vaginalis.
Right. Now, what's interesting here, according to the sources, is that the actual infection rate for Trichomonas doesn't seem to increase during pregnancy.
Oh, really?
Yeah.
Yeah.
And the clinical signs, the symptoms, they're pretty much exactly the same as you'd see in someone who isn't pregnant.
So the mastery point here isn't really about spotting it differently, but about the treatment, specifically the timing of the drug.
Precisely. The standard treatment is metronidazole. You probably know it as Flagyl. Usually it's 200 milligrams 3 times a day for 7 days.
Okay.
However, and this is the absolute critical restriction, the rule you just cannot break, metronidazole must be avoided completely in the first trimester.
Completely avoided. Why is that? Is there a known risk?
There's a known, though generally considered low, theoretical risk to the developing fetus. So standard practice is to delay treatment until the second trimester, or even later if possible, just to mitigate that risk.
Makes sense. And what about follow-up? Is there something else that's absolutely required to make sure it's gone for good?
Yes, absolutely critical for preventing quick reinfection. The husband or sexual partner must be treated at the same time, even if they have no symptoms at all.
Right, you're treating the whole cycle.
You're treating the infectious cycle, exactly, not just the person showing symptoms.
Okay. Let's pivot then to Monilia vaginitis, caused by Candida albicans. The sources say this one is more common during pregnancy than Trichomonas. Why? What is it about pregnancy that helps this fungus thrive?
Well, this is like a perfect storm of factors, environmentally speaking. Candida albicans loves very specific conditions.
Okay.
And pregnancy creates 2 big shifts that favor it. First, you get a highly acidic pH in the vaginal secretions.
Right.
And second, it's quite common to find sugar, glycosuria, in the urine during pregnancy.
That second factor, the sugar, immediately points to a high-risk group, doesn't it?
It absolutely does.
Yeah.
It makes perfect sense then that Monilia vaginitis is significantly more common in diabetic pregnancies, where glucose control can be a challenge and sugar in the urine is just more likely.
And the treatment protocol reflects this being a fungal issue, focusing on local action.
Exactly. We shift away from systemic antibiotics and use targeted antifungals.
Wow.
The standard is miconazole vaginal cream.
Okay.
And the protocol is quite specific. 1 full applicator, placed high up in the vagina, right at bedtime, and you do that for 7 nights straight.
And using a cream locally minimizes drug exposure for the fetus too, I assume.
That's the principle, yes. minimize systemic absorption, limit any unnecessary fetal exposure.
Okay. Now let's talk about a non-infectious condition that often causes confusion, hormonal ectopi. Sometimes people call it pregnancy erosion. Now, erosion sounds pretty alarming.
It really does sound alarming, doesn't it?
Yeah.
But it's actually a direct and totally benign result of that intense hyperestrogenism we mentioned, all that estrogen.
Exactly.
Those high estrogen levels basically trigger a marked hyperplasia that's an accelerated but importantly non-malignant growth of the endocervical mucosa, the lining inside the cervical canal.
Can you walk us through what that looks like anatomically? What's actually happening?
Sure. So normally you have this type of cell, columnar epithelium, just inside the cervical canal. But with this hormonal push, this columnar epithelium kind of grows downwards or outwards beyond the external opening, the us. And it replaces the tougher squamous epithelium that's normally on the outside surface of the cervix. That area can look quite red and raw, which is why it historically got the name erosion.
So as clinicians, how can we confidently tell this benign process apart from something potentially serious, like cancer or precancer?
There are 3 key characteristics to look for. First, it usually appears for the very first time during pregnancy, and it's typically circumoral, like a smooth, continuous red ring right around the us. Second, and this is probably the most crucial difference from, say, a cancer or a fragile polyp, it does not bleed to touch during a gentle speculum exam.
That's the vital clue. Doesn't bleed on touch.
Vital. And third, the only symptom should be that increased discharge we talked about, copious, mucoid, but non-irritating.
Got it. And the outcome is generally good.
Absolutely reassuring. It's managed conservatively because we expect spontaneous regression. It typically just goes away on its own about 6 to 8 weeks after delivery, once those hormone levels drop back to normal.
Right. What pregnancy creates, the postpartum period often resolves.
Nicely put, yes.
The sources also mention that women on oral contraceptives can show similar lesions. Does that just reinforce the hormonal link?
It really does. It confirms the underlying mechanism is all about estrogen, whether it's synthetic estrogen from a pill or the high levels of endogenous estrogen during pregnancy. The cervix responds in the same way with that hyperplastic downgrowth.
Okay, let's move on now to actual physical obstacles within the cervix that can complicate pregnancy. Starting with the cervical polyp. This small growth can cause significant diagnostic confusion at different stages, can it?
Oh, absolutely. Because the pregnant cervix is so incredibly vascular, these polyps bleed really easily.
Right.
So in the early months, maybe the first trimester, that bleeding looks almost exactly like a threatened abortion. Clinically, it's very hard to tell apart just based on symptoms.
Okay.
Then later in pregnancy, say third trimester, the bleeding has to be recognized as a potential extraplacental cause of antepartum hemorrhage, APH, meaning the bleeding isn't coming from the placenta itself, which is often the main concern with APH.
And that distinction is critical because placental APH often means urgent delivery, right?
Mm-hmm.
So how do we nail down the diagnosis if it's potentially confusing?
Confirmation is usually quite straightforward with the speculum exam. You just need to visualize the cervix and see the polyp and the management. It needs to be removed just like you would in a non-pregnant patient. And this is non-negotiable. The removed tissue must be sent for histology.
Why is that so crucial?
To absolutely rule out any underlying cellular abnormality or even a hidden malignancy that might just be presenting as a simple polyp, you can't skip the histology.
Makes sense. Okay, next up. Acquired cervical abnormalities, specifically scarring. This is usually the result of some past procedure, right? What kind of procedures typically lead to this kind of inelastic scarring?
Yeah, we usually see this after fairly significant procedures, either excisional ones where tissue was removed or destructive ones.
Oh.
Things like cervical amputation, which might have been part of an old operation for prolapse called Fothergill's operation, or maybe after aggressive treatments like depauterization or diathermy, perhaps done years ago for chronic cervicitis.
So if the cervix is scarred and inelastic, what's the big worry during labor? What's the immediate obstetric consequence?
The main danger is that the scarred tissue just doesn't have the natural ability to thin out a face and open up, dilate properly when labor starts.
Right. It can't stretch.
Exactly. The cervix might stay thick and rigid. We call that secondary cervical dystocia. And if that scarring is really extensive and it just won't yield to the contractions, well, a cesarean section becomes necessary.
To avoid injury.
To avoid potentially catastrophic tears to the cervix, yes, it's about safe delivery.
And this issue of previous surgery isn't just limited to the cervix, is it? There's a specific rule for patients who've had vaginal reconstructive surgery, too.
Yes, there's a clear safety mandate here. Any patient who's had significant vaginal reconstructive surgery in the past must plan for delivery in a hospital setting, a fully equipped hospital.
Why the mandatory hospital setting?
The risk of that previous repair breaking down under the intense pressures of labor and delivery is just too high to risk being anywhere else. You need immediate access to surgical care if something goes wrong.
And sometimes, certain past operations mean an elective C-section is basically required from the outset.
That's correct.
Specifically, if a patient has a documented history of a particularly difficult repair for stress incontinence, or if they've had surgery to fix a vesicovaginal fistula where the tissue integrity was seriously compromised.
Okay.
Those situations strongly indicate the need for an elective cesarean section. The priority becomes protecting those complex repaired structures. A potentially difficult vaginal delivery is just too risky for that prior surgical work.
All right, shifting gears now to congenital malformations, issues with the shape of the uterus or vagina that someone is born with. The outline mentions severity matters, but it's the moderate ones that often cause the most trouble in pregnancy. Why is that?
Well, think about it. Severe malformations often lead to infertility in the first place, so pregnancy might not even occur.
True.
Minor ones might be so subtle they escape notice and don't cause significant problems.
Yeah.
But the moderate degree ones, they often allow conception to happen.
But the uterine cavity itself might lack the normal shape, the symmetry, or the ability to expand properly for a full-term pregnancy. This basic architectural flaw sets the stage for a lot of potential adverse effects during pregnancy and labor.
Okay, before we get into those specific effects, let's talk about diagnosis. These can often go unnoticed until something goes wrong, right? What are the main ways a clinician might actually discover one of these malformations? The sources list 5 pathways.
Yeah, diagnosis can be sort of an accidental finding or sometimes part of a specific investigation. The 5 main ways are, first, just by looking during an abdominal exam, a clinician might notice an unusual shape or notch at the top of the uterus, the fundus. Second, it might be discovered during a cesarean section when the surgeon can actually see the uterus directly. Third, during a procedure like manual removal of the placenta, or maybe an evacuation after a miscarriage, the doctor might feel the abnormal shape from the inside. Fourth, through specialized imaging like hysterosalpingography, HSG, or hysteroscopy, though these are often done after pregnancy, maybe during an infertility workup. And fifth, during laparoscopy, again, often as part of investigating infertility.
Okay, so it can be found in various ways. Now, for the really critical part, the 10 key adverse effects linked to these uterine malformations. This list really shows how structure impacts function in pregnancy.
It absolutely does. We can kind of group these risks into maybe 3 main themes. First, issues with actually maintaining the pregnancy.
Right.
This includes things like recurrent mid-trimester abortion miscarriages happening later in pregnancy and also preterm labor. The unusually shaped or smaller cavity often just can't support the pregnancy to term.
Okay, what's next?
Second, there's the risk of an acute mechanical disaster. The most dramatic is rupture of a pregnant rudimentary horn. This is a type of cornual pregnancy where the pregnancy implants in a small, underdeveloped part of a bicornuate uterus. That rupture is a life-threatening emergency.
Wow.
Third, issues related to delivery mechanics. This includes malpresentation, the baby being in an abnormal position like transverse lie or breech, and often this happens repeatedly in subsequent pregnancies. Also, abnormal uterine action during labor, like uterine inertia where contractions are weak, or asymmetrical contractions because the 2 horns aren't working together properly, and non-engagement where the baby's head doesn't descend into the pelvis.
That's a lot already. What else?
Then there's fetal compromise. We can see fetal growth restriction, or FGR, possibly because the blood supply in one horn or near a septum isn't optimal, and risks after delivery too. Higher risk of postpartum hemorrhage, PPH, maybe due to an abnormal placental site or the placenta getting stuck, retained placenta, and even obstructed labor, where the non-pregnant horn of a bicornuate uterus actually physically blocks the baby's path down.
So the non-pregnant part gets in the way.
It can, yeah.
Yeah.
And finally, just an overall increased need for operative interference, more forceps, ventus, or C-sections.
That list really paints a picture. Structure is destiny in these cases. The common types we're talking about are arcuate, with that slight dip in the fundus.
Yep, the mildest form usually.
Subseptate, with a partial wall inside.
Correct.
And bicornuate, the classic heart-shaped uterus with 2 horns, which might be equal or unequal in size, and 1 horn could even be rudimentary, like you mentioned.
Exactly. Those are the main ones. causing obstetric issues.
What about the vagina? Can malformations there cause problems?
Well, a vertical vaginal septum, a wall running down the middle, usually doesn't cause much difficulty during delivery. It might tear, but it rarely obstructs things significantly.
Okay.
But a transverse septum one running across like a shelf or partial atresia where it's incompletely formed can block descent. That might actually require a surgical incision during labor to allow the baby to pass.
Got it. Okay, let's transition to a really rare but potentially catastrophic event. Torsion of the gravid uterus. This is the uterus twisting on its long axis.
Yes, exactly. Minor degrees of rotation are actually quite common and don't cause problems. But we're focusing here on major torsion twisting 270 degrees or more. That causes acute, severe symptoms, but thankfully it's extremely rare.
And what usually predisposes the uterus to twist like that?
It almost always happens when there's some other structural factor involved, usually the presence of a large fibroid, which makes the uterus unbalanced, or having a bicornuate uterus itself. These act like an anchor point or an uneven weight that allows the twist to happen.
The description of the presentation sounds terrifying. Acute abdomen, shock. What are the key things it gets confused with? What are the main differentials?
It's a diagnostic nightmare because it mimics other emergencies. In the early months, the intense pain and signs of internal bleeding and shock look exactly like a disturbed ectopic pregnancy.
Right.
Later in pregnancy, it's often mistaken for abruptio placental abruption because you get that sudden severe pain and a very tense, tender uterus.
So with such dramatic and overlapping symptoms, how do you possibly make the right diagnosis? Is there any specific clue?
There is one potential clinical finding that can be quite suggestive if you can elicit it. An internal examination might reveal a characteristic spiraling of the vagina. You can feel the twist.
Ah, interesting.
Imaging like sonography or even MRI can definitely help visualize the twist and any associated fibroid or uterine shape anomaly. But honestly, because it's so acute and emergent, the definitive confirmation often only happens when they open the abdomen in surgery, a laparotomy.
And once torsion is confirmed, there's a critical, non-negotiable step regarding the timing of any incision, right?
Absolutely critical for mastery. The uterus must be repositioned anatomically first. It needs to be untwisted, detorsed, and brought back to its normal alignment before you make any incision on it, like for a C-section.
Why is that sequence so important?
If you cut into the uterus while its blood supply, the pedicle, is still twisted, you risk massive hemorrhage and further damage to already compromised tissues. Untwist first, then incise.
Okay, we have to move now to what is arguably the most serious topic in this deep dive, carcinoma of the cervix that occurs during pregnancy. It's relatively rare, about 1 in 2,500 pregnancies, but it obviously changes everything.
It fundamentally alters all management, yes, and early, accurate detection is just paramount. We typically find cases in two main ways.
How so?
Well, some are asymptomatic. They get picked up through routine cervical screening, the Pap smear, during a standard antenatal checkup. If that smear comes back abnormal, showing dyskaryotic cells, the next step is immediate colposcopy with a directed biopsy.
And the symptomatic cases. They usually present with bleeding.
Correct. The bleeding often mimics other more common pregnancy issues. In the first half, it looks like a threatened abortion. In the second half, it might look like antepartum hemorrhage.
So vigilance is key.
Absolutely. Any unexplained bleeding during pregnancy demands a speculum examination to directly visualize the cervix. And if you see any suspicious lesion, a biopsy must be taken right away for confirmation.
Now, here's where pregnancy itself makes things incredibly difficult. Those physiological changes we talked about, the softening, the vascularity, they can actively mask the signs of cancer. Can you detail the 3 specific diagnostic pitfalls?
Yes, this is where gestation really works against easy diagnosis. First, the cervix normally feels firm or hard indurated with cancer, but the softening and edema of pregnancy can completely mask that feeling. It might feel deceptively soft, leading to missed or delayed diagnosis.
Okay, that's a major pitfall. What else?
Second, benign things can look malignant. Remember that hormonal ectopi or even a simple polyp. Because of the intense vascularity, they can bleed quite easily on touch during an exam.
Right.
This can falsely mimic the friability, the pendencyta bleed that's characteristic of cervical cancer. So you might biopsy something benign thinking it's worse, or worse, dismiss something serious.
And the third pitfall?
Understaging. The edema and softening make it really hard to accurately feel how far the tumor might have spread into the surrounding tissues, the perimetrium, just by physical exam. You might think it's an earlier stage than it actually is.
So Given these challenges with just a physical exam, how do doctors accurately figure out the extent of the disease while still protecting the fetus?
We have to rely heavily on imaging. MRI is the preferred tool for assessing pelvic spread because it gives great soft tissue detail without using ionizing radiation.
Right, avoiding radiation is key.
Definitely. We can also use cystoscopy to look inside the bladder and sigmoidoscopy to check the rectum for any direct invasion. But one tool we generally avoid in pregnancy is computerized tomography, CT scanning. It's often standard for cancer staging, but the radiation dose is a concern for the fetus.
Okay, let's talk about the interplay. Does pregnancy affect the cancer itself? The sources seem clear on this.
Yeah, the data suggests the pregnancy itself doesn't actually accelerate or change the malignant process. The cancer grows as it would otherwise, but there's a massive risk after delivery or intervention.
What's that risk?
There can be a rapid spread or dissemination of the cancer cells if the cervix is traumatized. This can happen during a vaginal delivery or even during an induced abortion. That potential for spread is why management is so aggressive and carefully planned.
That's a critical point. And the sources mention HPV vaccination.
Yes, just to note that human papillomavirus or HPV vaccination, which is preventative before exposure, is explicitly not recommended during pregnancy.
Okay. Now, flipping it around, how does the cancer itself impact the pregnancy? There are 6 listed risks.
The presence of the cancer, especially if it compromises the structure of the cervix, increases several risks. Higher chance of abortion or premature labor, causing problems with dilation during labor, secondary cervical dystocia, leading to injury and severe bleeding, traumatic PPH, from the friable cervix or lower uterus during delivery, and also increasing the risk of postpartum infections like lochiometra, retained lochia, pyometra, pus in the uterus, and generalized uterine sepsis.
That's a grim list. Yeah. Before we get into invasive cancer treatment, what about just an abnormal smear showing, say, intense basal cell hyperactivity? Is that always cancer?
Not necessarily. That finding can actually be a benign change related to the pregnancy hormones. So the standard approach is conservative follow-up. You monitor the patient with repeat cytology and colposcopy after delivery. Usually that hyperactivity reverts back to normal within about 6 weeks postpartum.
Okay, good to know. Now let's get into the actual treatment protocol, starting with the very earliest stage, carcinoma in situ, or CIS.
Right, CIS is non-invasive cancer. So the management during pregnancy is careful observation, periodic cytology, and colposcopy. The absolute key takeaway here is that because it's non-invasive, a vaginal delivery is not contraindicated for CIS.
Okay, that's important. What about microinvasive disease, where it's just starting to invade, confirmed by a cone biopsy?
If microinvasive disease is confirmed and the edges, the margins of the cone biopsy specimen are clear, meaning it looks like all the disease was removed,
Right.
then you can generally continue with conservative management until delivery. You allow the pregnancy to reach term or near term, and then reevaluate postpartum for any necessary definitive therapy, like a hysterectomy.
Okay, that makes sense. Now we get into the really tough decisions with early invasive cancer stages IB and IIA. The plan here seems heavily dependent on how far along the pregnancy is and what the mother wants. Let's start with the first trimester.
Yeah, in the first trimester, the standard approach is unfortunately quite aggressive towards the pregnancy. It involves a radical hysterectomy, removing the uterus, cervix, upper vagina, and surrounding tissues with the fetus still inside in utero.
Wow.
This is usually combined with removing pelvic lymph nodes, lymphadenectomy, and sampling nodes higher up along the aorta. Sometimes they might perform an oophorectomy surgically, moving the ovaries higher up to try and preserve ovarian function if radiation might be needed later.
Okay, that's a very difficult situation. What if the cancer is found in the third trimester?
In the third trimester, the baby is potentially viable, so the focus shifts slightly. The protocol is typically a classical cesarean delivery first. That's an incision high up on the uterus, on the fundus, to stay well away from the cervix and lower segment where the cancer might be.
Right.
And then immediately following the C-section in the same operation, they proceed with the radical hysterectomy and the pelvic lymphadenectomy.
Now, the sources mention an alternative, a sort of bridging strategy using chemotherapy. Can you explain that?
Yes, this is a more nuanced approach, using what's called neoadjuvant chemotherapy. The idea is to use chemotherapy drugs, usually platinum-based ones, before surgery.
Why?
The chemo aims to halt or shrink the tumor growth temporarily. This can buy precious time, maybe 7 to 15 weeks, according to the sources, allowing the fetus to mature further and reducing the risks of extreme prematurity.
Ah, I see.
After this period of chemotherapy and fetal maturation, the plan is then the classical C-section followed by the radical hysterectomy. It's a calculated balance, the consensus being that the significant risks of severe prematurity often outweigh the risks associated with the chemotherapy itself during that period.
That's a sophisticated approach.
Yeah.
What about advanced invasive disease stages 3 and 4? The prognosis is much worse here. What's the plan in the first trimester?
When the disease is advanced, the priority has to be the mother's immediate treatment. In the first trimester, this usually involves starting chemotherapy combined with external beam radiation therapy.
And the pregnancy.
This aggressive treatment typically leads to a spontaneous abortion within about 2 to 5 weeks. If not, a uterine evacuation might be needed. After the uterus is empty, treatment continues, often with brachytherapy, that's internal radiation targeted directly at the tumor area.
And if advanced cancer is found later, in the second or third trimester?
Again, the sequence changes to prioritize a safe delivery first. You'd perform a classical cesarean section essential to avoid bleeding and tumor spread. This would then be followed by neoadjuvant chemotherapy and then the full course of radiation, both external beam and brachytherapy.
So across all the invasive stages, avoiding vaginal delivery seems to be a constant theme.
Absolutely non-negotiable. Vaginal delivery is avoided because of the high risk of spreading the cancer cells due to cervical trauma, the risk of massive bleeding from the very friable cancerous tissue, and the likelihood that the cervix wouldn't dilate properly anyway, cervical dystocia.
So the standard is C-section, then definitive treatment.
Classical cesarean section, followed by the definitive cancer therapy appropriate for the stage. That's the gold standard.
Despite all this complexity and the seriousness of the diagnosis,
Yeah.
what's the overall outlook for the mother's survival?
This is actually a somewhat encouraging point from the sources. Stage for stage, the survival outcomes for women diagnosed with cervical cancer during pregnancy are reported to be no different compared to non-pregnant women with the same stage of cancer.
Really?
Yes. It highlights that early detection, accurate staging, and prompt, tailored, aggressive treatment can achieve comparable results even with the added complexities of pregnancy.
Okay, let's move on to something much more common. Leiomyomas, or fibroids, complicating pregnancy. About 1 in 1,000 pregnancies. The management philosophy here seems quite different, almost defined by restraint.
That's a great way to put it. The core principle, the mantra almost, is do not do anything to the fibroid whenever possible. Avoid surgery unless absolutely necessary.
Just manage symptoms and wait.
Pretty much. Manage symptoms, monitor, and intervene only for specific acute complications.
But these fibroids aren't just passive passengers, are they? The sources list 8 potential risks they pose to the pregnancy.
No, they're definitely not passive. They can cause mechanical problems, pressure symptoms, like urinary retention if it's pressing on the bladder, or constipation if it's pressing on the bowel, especially if the fibroid is low down.
Okay.
They also increase the risk of abortion, particularly early on, and preterm labor later. They can cause malpresentation because they distort the uterine cavity, preventing the baby from settling head down.
Right.
Also, non-engagement of the fetal head for the same reason. There's a potential link to placental abruption, though the mechanism isn't perfectly clear. And then there's the risk of that acute event we need to discuss, red degeneration.
Okay, we'll get to that. But first, the flip side. How does the pregnancy itself affect the fibroids? There's 6 listed changes.
Right. The pregnancy actively changes the fibroids too. First, they often increase in size. This is mainly due to the increased blood flow, edema, swelling, and some actual hypertrophy of the muscle cells within the fibroid. They also tend to feel much softer during pregnancy.
Makes sense with all the hormones and blood flow.
Exactly. Second, their position can change, or they might flatten out as the uterus stretches around them. Third, they're prone to those degenerative changes, especially red degeneration.
Okay.
Fourth, a pedunculated fibroid one on a stalk can twist, causing acute pain, portion. And fifth and sixth, infection or polypoidal changes where a submucous fibroid protrudes into the cavity. These are actually more common after delivery in the puerperium.
Okay, let's zero in on red degeneration. The outline calls it really interesting because of its specific cause and the unusual treatment approach. When does this usually happen?
It typically occurs in a large fibroid and usually during the second half of pregnancy or sometimes early in the postpartum period.
And what is it pathologically?
It's essentially a hemorrhagic infarction. The blood supply to a part of the fibroid gets compromised, leading to tissue death, necrosis, and bleeding within the fibroid itself. The key master point here is that primary infection plays no part in causing red degeneration. It's initially a sterile vascular event.
Interesting. And what does it look like if you were to see it?
Grossly, visually, the fibroid develops these characteristic dark red areas. If you cut into it, it has this classic description of a raw beef appearance. Often there are cystic spaces within it too.
Raw beef appearance.
And sometimes it's noted to have a distinct fishy odor that's thought to be from the breakdown products. The red color itself comes from all the red blood cells that have broken down, hemolyzed, and released hemoglobin into the dead tissue. Under the microscope, you just see necrosis and thrombosed blood vessels.
Okay, but clinically, the presentation sounds like an acute emergency, doesn't it?
Yeah.
Making it easy to misdiagnose.
Highly likely to be misdiagnosed. It presents as a classic acute abdomen. The patient gets sudden, severe focal pain right over where the fibroid is. They might feel generally unwell, have a fever, a rapid pulse. The abdomen is tender, maybe rigid locally over the fibroid, and blood tests often show a high white cell count, leukocytosis.
So what does it get confused with?
Very commonly confused with acute appendicitis, especially if the fibroid and pain are on the right side. Or it might be mistaken for a twisted ovarian tumor. The diagnosis is often only made definitively at laparotomy when they go in looking for something else.
So given that it looks like a surgical emergency, why is the treatment strictly conservative? Why the do-nothing approach if you find it?
Because operating on a fibroid during pregnancy, especially an intramural one within the uterine wall that's undergoing red degeneration, carries an extremely high risk of profuse, potentially uncontrollable hemorrhage.
Ah, the vascularity again.
Exactly. The pregnant uterus is just a massive vascular organ, so the mandated approach is conservative. Strict bed rest, antibiotics like ampicillin, usually 500 milligrams, 3 times a daily for 7 days, mostly prophylactically against secondary infection, strong pain relief, analgesics, and maybe sedatives.
And does it usually resolve?
Yes, the symptoms typically settle down significantly within about 10 days as the body gradually deals with the infarcted tissue.
That really highlights the importance of restraint. So what if a surgeon does operate, thinking it's appendicitis or torsion, and then finds red degeneration instead? What's the protocol then?
This is a critical decision point. If laparotomy is done under a mistaken diagnosis and red degeneration of an intramural or subserous fibroid is found, the correct action is generally to close the abdomen without intervening on the fibroid.
Just close up.
Yes. The only exception might be if it's a pedunculated subserous fibroid one dangling on a clear stalk. In that specific case, the stalk can sometimes be safely clamped and the fibroid removed without excessive bleeding risk. But otherwise, leave it alone.
Wow. Okay. Even diagnosing a fibroid without degeneration sounds tricky during pregnancy.
It really is. Because they become so soft and often flatten out, it can be very difficult clinically to distinguish a fibroid from just the normal pregnant uterus, or maybe an ovarian cyst next to it, or even the non-pregnant horn of a bicornuate uterus.
So you might miss the fibroid or miss the pregnancy.
It's common for a large fibroid to obscure an early pregnancy, or for the softening of the fibroid later on to make it blend in with the uterus.
So imaging is essential for certainty then.
Absolutely. Ultrasound sonography is usually excellent for confirming the presence, number, and location of fibroids. Color Doppler can help assess their blood flow. An MRI gives the most accurate picture of their size and, very importantly, their relationship to where the placenta has implanted.
Why is the placental location so important?
Because a fibroid located behind the placenta could potentially interfere with placental function or increase the risk of bleeding, and a fibroid in the lower segment could obstruct delivery.
Which brings us to delivery management. When does a fibroid necessitate an elective C-section?
Clear indications would be a fibroid located in the cervix itself, physically blocking the exit, a large fibroid in the broad ligament, which distorts the lower uterine segment where the incision would normally be made, or if the fibroid is associated with other complications like persistent malpresentation, breach, or transverse, that can't be corrected.
And what about removing the fibroid during the C-section? Myomectomy.
Generally, that's strongly contraindicated. Trying to remove fibroids, especially those deep within the uterine wall, intramural, at the time of C-section carries a very high risk of severe hemorrhage. That principle of non-intervention usually holds, even when you're already in the abdomen. Okay, moving sideways slightly to ovarian tumors during pregnancy. These occur in about 1 in 2,000 pregnancies. And there's an interesting point here about tumor type.
What's that?
The incidence of germ cell tumors, specifically dermoid cysts, which contain hair, teeth, etc., is actually increased about twofold in pregnancy. But it's not that pregnancy causes them.
It's just because they're common in that age group anyway.
Exactly. Dermoids are most prevalent in women of childbearing age, so you're simply more likely to find one when scanning pregnant women. Thankfully, malignant ovarian tumors remain extremely rare during pregnancy, maybe 1 in 30,000.
What effects does the pregnancy have on the tumor itself? Does it change things?
It does. First, the tumor gets relocated, pushed up out of the pelvis as the uterus grows. This movement increases the risk of the most significant complication: torsion of the pedicle, the stalk attaching the ovary to the blood supply.
And there are specific times when torsion is more likely.
Yes, 2 critical windows. First, around 8 to 10 weeks of gestation, as the uterus rapidly expands and lifts the ovary and tumor out of the true pelvis. Second, in the early puerperium, right after delivery, when the uterus suddenly shrinks, creating more space and instability in the abdomen, allowing the tumor to twist.
What other complications can happen to the tumor?
You can get bleeding within the cyst, intracystic hemorrhage. The cyst can rupture, or it can become infected, especially following an abortion or delivery, possibly due to thrombosis in the pelvic veins nearby.
Diagnostically, how do you differentiate an ovarian cyst from the pregnant uterus, especially on an internal exam? Is there a specific technique?
There's a clinical sign called the Hingorani sign. You place the patient in the Trendelenburg position, head down, feet up. Then, during the vaginal exam, you try to feel for a groove or separation between the firm pregnant uterus and the usually more cystic-feeling ovarian swelling. Having the patient tilted helps gravity separate them slightly. But honestly, ultrasound, USG, and MRI are highly reliable for confirming it's a separate ovarian mass.
Got it. Now let's talk about treatment timing. Specifically for an uncomplicated tumor found during pregnancy, there seems to be an ideal window for surgery.
Yes, there's a well-established optimal time for elective removal between the 14th and 18th week of gestation.
Why that specific window?
2 main reasons. First, the risk of triggering a miscarriage is generally lowest during this mid-trimester period, after the corpus luteum's initial crucial role is over. Second, by this time, the uterus and the tumor have usually risen sufficiently out of the deep pelvis, making surgical access much easier and safer. The pedicle is easier to identify and ligate.
What if the tumor isn't found until much later, say after 36 weeks?
If the pregnancy is already near term, the elective operation is usually postponed. You'd monitor the tumor carefully, proceed with delivery, and then plan to remove the tumor early in the puerperium, often around 6 weeks postpartum.
But what if the tumor becomes complicated? It twists, ruptures, or bleeds internally. Does the stage of pregnancy matter then?
No. If a complication occurs, the tumor must be removed surgically, irrespective of the period of gestation. The risk to the mother from the acute event, like torsion cutting off blood supply or rupture causing peritonitis, outweighs the potential risk to the fetus from emergency surgery.
And post-op care?
Post-operatively, you'd maintain strong pain relief for at least 48 hours to try and minimize uterine contractions and reduce the risk of preterm labor triggered by the surgery.
Okay. Let's shift now to a positional problem. The retroverted gravid uterus. That's when the uterus is tilted backward. And it's quite common early on.
Yes, about 10% of women have a retroverted uterus in the first trimester. But for the vast majority, it's not a problem.
Right.
Because as the uterus grows, it naturally rises up out of the pelvis, usually beyond the sacral promontory, the bony ledge at the back, by about 12 weeks. It spontaneously corrects itself, becomes aneverted, and the pregnancy continues normally.
The danger arises when it fails to correct, gets stuck back there. That's called incarceration.
Exactly. Incarceration is the failure of spontaneous rectification, typically occurring between 12 and 16 weeks. The growing uterus gets trapped below the sacral promontory.
What stops it from rising up? What causes it to get stuck?
Sometimes there's a clear mechanical reason. Maybe the sacral promontory is unusually prominent, making it hard to get past. Or perhaps there are adhesions, scar tissue holding the uterus back from previous pelvic surgery or infection. Or maybe another pelvic tumor, like a fibroid or ovarian cyst, is physically blocking its path.
Okay.
But honestly, in the majority of cases, we don't find a specific reason. It's termed idiopathic. It just fails to rise.
If it does get incarcerated, the anatomical changes sound quite severe, especially for the bladder and urethra. Let's start with the uterus itself.
Right. With the main body, fundus, trapped posteriorly, the cervix gets pulled sharply upwards and forwards. It can end up positioned very high, sometimes right behind the upper edge of the pubic bone, symphysis pubis.
Okay.
There's also a rare but very dangerous variation called anterior sacculation. This is where the back wall of the uterus stays completely stuck, and the pregnancy forces the anterior wall to stretch massively to accommodate the growth. The whole uterus balloons forward.
That sounds incredibly risky.
Yeah.
What about the bladder and urethra? How are they affected by the uterus being stuck backward?
They suffer dramatically. The cervix pulling upwards stretches the urethra, making it much longer than normal. This stretching, combined with the direct mechanical compression from the trapped uterus and secondary edema around the bladder neck, leads to acute urinary retention. The woman suddenly finds she can't pass urine.
And this can lead to that paradoxical incontinence.
Yes, exactly. The bladder becomes hugely distended, but the pressure gets so high that small amounts of urine might be forced out involuntarily, especially with straining. The patient might think they are passing urine, but the bladder remains dangerously full. It's a crucial sign not to miss.
If this retention isn't treated promptly, the consequences can be dire, right?
Absolutely life-threatening if neglected. Chronic overdistension causes the bladder walls to thicken and lose function. Severe urinary tract infections, cystitis ascending to become pyelonephritis, are very common and can lead to kidney damage and uremia.
And even rupture.
In grossly neglected cases, yes. The massively distended bladder can actually rupture into the abdominal cavity, intraperitoneal rupture, causing severe peritonitis. Long-term obstruction can also lead to kidney damage, obstructive nephropathy.
So what's the absolute first step in managing incarcerated retroverted uterus with retention?
The immediate critical first step is bladder drainage. You need to insert a Foley catheter to allow continuous drainage, but it should be done slowly initially to avoid rapid decompression complications.
Okay, catheter first. Then what?
Then bed rest, often in the prone, face down, or Sims, side-lying position, which helps tilt the uterus forward, and start antibiotics like ampicillin to treat or prevent a UTI, which is almost inevitable with that stasis.
And does that often work on its own?
Frequently, yes. Once the pressure from the full bladder is relieved, the uterus often spontaneously corrects its position within about 48 hours.
What if it doesn't correct with just drainage and positioning?
Then you move to manual correction. This usually requires sedation or anesthesia. The clinician attempts to gently push the trapped fundus upwards, either through the posterior vaginal fornix or sometimes via the rectum, while simultaneously pulling the cervix downwards and backwards. It's often done in the Sims or knee chest position.
And if that works?
If manual correction is successful, a Hodge-Smith pessary, which is shaped to hold the uterus forward, is usually inserted and kept in place until about the 18th to 20th week, by which time the uterus is large enough that it shouldn't fall back again.
What about really stubborn cases? Or if that anterior sacculation is diagnosed, is surgery needed then?
For truly obstinate cases where manual correction fails, or if adhesions are suspected, laparotomy or laparoscopy might be needed to physically free the uterus. And if anterior sacculation is diagnosed, delivery must be by cesarean section.
And there's a critical point about the C-section technique in sacculation cases.
Hugely critical, probably one of the most important technical details in this entire discussion. With anterior sacculation, the surgeon absolutely must avoid the standard low transverse uterine incision.
Why? Where should the incision be?
Because the structure presenting low down might actually be the hyperstretched bladder or the anterior vaginal wall, not the lower uterine segment. So the abdominal incision needs to be made higher up, often above the umbilicus. The surgeon must first carefully identify the uterine fundus, which will be high, deliver the entire uterus out of the abdomen to restore the anatomy, and only then make the incision on the uterus itself for delivery.
To avoid cutting the bladder or vagina by mistake.
Precisely. It's a potential catastrophe if missed.
Okay, our final topic for this deep dive. Genital prolapse during pregnancy. Affects about 1 in 250 pregnancies. It's worth noting, though, if the prolapse is really severe, like the cervix is permanently outside, pregnancy probably wouldn't happen easily anyway.
That's generally true, yes. Conception can be difficult with severe prolapse, but milder degrees can certainly coexist with pregnancy.
And does pregnancy make the prolapse worse?
Dramatically worse, especially in the early stages. The increasing weight of the growing uterus, combined with that massive increase in pelvic blood flow and tissue softening,
Right.
it all causes the existing anatomical weaknesses to become much more pronounced. You see marked edema and hypertrophy, swelling and enlargement of the cervix if it's prolapsing, the cystocele, bladder bulge, and rectocele, rectal bulge, become much more obvious, and any pre-existing stress incontinence usually gets significantly worse.
What are the main risks or complications this causes for the mother and the pregnancy itself?
Well, if the cervix is protruding outside the vagina, it's exposed to friction and drying, increasing the risk of developing a decubitus ulcer, an open sore.
Right.
There's also the risk, similar to retroversion, that if the prolapse uterus fails to rise up above the pelvic brim by around the 16th week, it could potentially become incarcerated, though this is less common than with retroversion. For the pregnancy itself, prolapse increases the risk of miscarriage, it causes significant maternal discomfort, and importantly, increases the risk of premature rupture of membranes, PROM, and subsequent infection, chorioamnionitis, because the membranes might be closer to the outside environment.
So what's the core management strategy during pregnancy to try and minimize these risks?
The main principle is if the cervix is prolapsing outside the vagina, it needs to be replaced back inside, and then it needs to be held there.
How do you hold it in place?
Yeah, usually with a ring pessary. This is inserted into the vagina to provide support and keep the cervix and uterus elevated. The pessary is typically kept in until about the 18th to 20th week of pregnancy. By then, the uterus is usually large enough to stay up on its own.
What about the swelling and congestion?
To help reduce the edema and congestion of the prolapse tissues, particularly the cervix, gauze soaked in a mixture of glycerin and acroflavine can be applied. The glycerin draws out fluid osmotically.
Okay, let's talk about labor. Managing labor with prolapse requires high vigilance, right? How do you help the cervix dilate if it's potentially swollen and prolapsed?
First, the patient should be on bed rest once labor starts, or if membranes rupture, to prevent further prolapse and infection risk. Then, intravaginal plugging again, often using gauze soaked in glycerin and acroflavine, can be helpful. It aims to reduce that cervical edema and congestion, hopefully making it easier for the cervix to dilate.
What if conservative measures aren't enough? The cervix stays thick or just won't open?
Yeah.
What are the delivery options then?
The choice really depends on the specific situation, primarily the baby's position station and the state of the cervix.
Okay.
Option 1. If the baby's head is deeply engaged in the pelvis, but the cervix is fully effaced, thinned out, but just not dilating like a tight ring, sometimes called an annular constriction, then delivery might be possible using Derson's incisions.
What are those?
These are deliberate surgical cuts made into the cervix, typically at the 2 o'clock and 10 o'clock positions, to open it up. This would then be immediately followed by an instrumental delivery using ventus, vacuum, or forceps.
And the second option?
Option 2. If the baby's head is still high up, or if the cervix remains very thick, scarred from previous issues, or just grossly edematous and unlikely to dilate safely, then a cesarean section is the much safer approach. Trying to force delivery through a problematic cervix risks severe tears.
Makes sense. And finally, what happens after delivery in the puerperium?
The patient usually needs to lie flat initially. If the prolapse is still evident, it might continue to be managed with the glycerin and acroflavine gauze packs. If the uterus isn't shrinking back well, subinvolution, a ring pessary might be used temporarily to provide support until things improve. Prophylactic antibiotics are also common given the increased manipulation and risk of infection. #outro.
You know, if we step back and look at everything we've covered today, there's a real common thread, isn't there? It's how those normal physiological changes of pregnancy, the hyperestrogenism, the tissue softening, that incredible vascularity, how they are both essential for the pregnancy. And the main reason things get so diagnostically confusing.
They mask things, they mimic things.
Exactly. And mastery in this area really comes down to understanding those nuances. Knowing the specific timing windows, like avoiding metronidazole early on, the 14 to 18-week sweet spot for ovarian tumor surgery, or understanding that red degeneration demands that strict conservative restraint even when it looks acute. Yeah, and realizing that sometimes structure really is fate. Whether it's that bicornuate uterus almost predestining malpresentation or old cervical scarring meaning elective C-section is the only safe route. And it's about knowing when to be incredibly aggressive, like that radical hysterectomy with the fetus in utero for early cervical cancer, versus knowing when absolute restraint is needed, like closing the abdomen on finding red degeneration to avoid catastrophic bleeding. It's that judgment call.
It really is. And thinking broader, we've focused very heavily today on conditions directly affecting the pelvis, the uterus, the cervix, the ovaries.
Right. Primarily gynecological and uterine issues interacting with pregnancy.
But pregnancy impacts the entire body so profoundly.
That's a great point. So here's a final thought for you, the listener, to maybe mull over. Given those massive systemic changes during pregnancy, the huge shifts in blood volume, the immune system modulation, ligaments becoming lysed, the whole vascular system adapting. What other conditions, things completely outside the reproductive tract, maybe vascular issues, autoimmune diseases, neurological conditions, might also have their presentation or their natural course fundamentally altered by pregnancy? Altered in ways that could lead to diagnostic confusion or oversight, just like the conditions we discussed today.
That's a fantastic question. That need to constantly question, to look beyond the obvious presentation because of the pregnancy overlay. That really defines true clinical mastery, doesn't it?
It really does. Something to keep exploring.
Indeed. Well, thank you for joining us for this very deep dive into some challenging obstetric scenarios.
And thank you for tuning in. We'll catch you next time for more essential knowledge extracted and analyzed right here on The Deep Dive.